Hello. I think Dr. Kasturi, you lost the connection. Arun?
Sir.
Yeah, I think Madam lost the connection,
Yes,
isn't it?
yes.
Yeah. Anyway, I think you can now flash the Madam CV. I will introduce her and
Ashara Madam from Coimbatore.
Oh, Dr. Kasturi is back. Okay.
Yeah.
okay.
Oh, I think I in between this thing had gone, is it?
Yeah, correct. Yeah. Okay.
Oh, I didn't know.
Yeah.
I was going on speaking. I'll not take much time. Welcome to everyone. It is a great pleasure to have Ashara Madam, eminent faculty, and thanks to Pai sir for preaching in such eminent faculty and great topic. Thank you, everyone.
Yeah, correct. Yeah. Okay.
I think there is some disturbance.
Crosstalk. Yeah. Okay. Okay, you
sir.
continue. Doctor.
Yes, sir. Thank you. And I really bring greetings from Kasoga family. And we are very happy to have you, madam, on this platform. Everybody is looking forward to listen to you. So I'll not come in the way. So welcome you once again. And thank you, Pai sir, for this webinar. Yes.
Thank you, Kasturi. Arun, can you put up Madam's CV? As Dr. Kasturi said, it's a great honor to have Dr. Asha Rao, who is the chairperson of Endometriosis Committee of FOXI for the year 2020 and 2022. Dr. Asha Rao has an experience of 25 years in assisted reproductive techniques, and she was the person to give the first IVF baby in Coimbatore. She's the director of Rao Hospital and CARE Center. She's the director for postdoctoral fellowship program in reproductive medicine, affiliated to Tamil Nadu, Dr. MGR University, Chennai. She's the past president of Coimbatore OBGYN Society for 2017 to 19, 93 to 94. She has been the organizing chairperson of EndoSite 2021 International Endometriosis, FOXI, and SEUD. She has been organizing person for UFOXI South Zone 2019.
I think that's good enough.
Yeah. So she has conducted many CMEs, conferences, and academic programs, a fantastic speaker as well, and a very nice human being. She's been almost like my elder sister. She has always invited me for all her CME programs and conferences. Over to you, Dr. Asha Rao.
Thank you so much, Dr. Pai, for those kind words. And at the outset, let me thank Dr. Muralidhar Pai and Dr. Kasturi and the team for having invited me here to speak on my favorite topic, that is adenomyosis. Let me just share the screen. Yeah, I think it's visible, right?
Yes.
Yes, madam, it's visible.
Yeah, bring you greetings from Coimbatore and from FOXI Endometriosis Committee. My journey into adenomyosis started in 1993 when we had a young woman of 34 years who was married already for 16 years. And she came with severe dysmenorrhea and infertility. And those days, all that we had to offer was laparoscopy. This was 1992. And we saw a globular enlarged uterus of 12 week size. And tubes looked apparently healthy, but no spill. And she was put on Danazol for 4 months. And when she stopped the medication, she promptly conceived. And the girl who was born in 1993, she got married last year, and it was such a happy occasion. So this is how our journey started in adenomyosis. And the disease which causes severe dysmenorrhea, menorrhagia, was earlier considered as a disease of 40 and Paris women. But today, more and more, it is being seen in younger women, seems to affect 30% of young women and infertile women, and diagnosing 22% of infertile women less than 40 years undergoing ART. And by definition, it is a benign invasion of endometrium into myometrium, producing a diffuse enlargement of the uterus. And on the microscopy, it shows endometrial glands and stroma surrounded by hypertrophic, hyperplastic myometrium. I think something. It causes historically diagnosed by histopathology at hysterectomy because it's a disease of Paris women. And now as when it is being seen in younger women, there's something.
It's jumping.
It's jumping, yeah.
And now it's corrected.
Okay. So, yeah. The effect of adenomyosis on fertility are impaired gamete transport leading to infertility, poor implantation, poor placentation, miscarriage, preterm labor, IUGR. All this can happen in young women. So whenever you see a woman coming to you with the enlarged uterus, menorrhagia, dysmenorrhea, one should really think of adenomyosis. A recent meta-analysis of IVF outcome demonstrated that endometriosis, adenomyosis is associated with lower rates of successful implantation and increased risk of pregnancy loss, translating into overall significant reduction in live birth rates. It can be asymptomatic in about 20% of women, but in about 50 to 60% of women, it causes menorrhagia, dysmenorrhea, and infertility and reproductive dysfunction in about 20% of women. So whenever you see women with dysmenorrhea, menorrhagia, kindly think of adenomyosis. And it is very important to differentiate adenomyosis from myoma. 28% of subfertile population can have adenomyosis alone. And 21% of women with endometriosis concomitantly had adenomyosis. It is a disease of the junctional zone, and junctional zone is normally hardly seen, and it can be only about 4 to 5 millimeters. And whenever it exceeds a thickness of 8 millimeter, you can suspect adenomyosis. And if it is about 10 to 12 millimeters, you can diagnose adenomyosis. And MRI used to be the best method of diagnosing adenomyosis earlier, but today more and more, we are able to diagnose adenomyosis with 80% accuracy with ultrasound. You may see a globular asymmetric uterus, irregular cystic spaces, myometrial striations, heterogeneous. There are about 7 criteria. If you have more than 3, you can diagnose adenomyosis. By the time you diagnose with 2D, you can see that this is a large uterus with the striations, heterogeneous myometrium, cystic areas, etc. By the time you diagnose with 2D, it might be a little late. So you have to learn to do a 3D ultrasound and color Doppler studies. With this, you can diagnose adenomyosis at a very early stage like this. This is the endometrium, myometrium, and this dark area here is a junctional zone. And this is the early infiltration of adenomyosis, and this is focal adenomyosis. This is how you should learn to diagnose adenomyosis in your young infertile patient, and do not wait for it to become a large globular uterus when you cannot do anything. If you diagnose at this stage, you can treat it with medication and perhaps suppress the disease and get good results for fertility. This is a cystic area in the posterior myometrium, and this is called as adenomyoma. I have seen sometimes people reporting posterior wall endometriotic cyst. It is not an endometriotic cyst, it is an adenomyoma, and it responds better to surgery rather than medical management. And how does adenomyosis happen? There seems to be local hyperestrogenism in these women, increased peristalsis, and tissue injury and repair. And this can lead to alterations at various levels like endometrium and myometrium. In myometrium, there can be myohyperplasia leading to enlargement of the uterus. In the endometrium, the factors that are favorable to implantation, like HOX8, 10 mRNA, integrin, interleukin 10, etc., are decreased. And factors which are not favorable to adenomyosis, to implantation, like B-catenin, interleukin 6, macrophages, natural killer cells may be increased, thus reducing the implantation and fertility. There can be dysregulation of endometrial proteins, altered uterine peristaltic activity because of destruction of the junctional zone, which is very important. And impaired implantation, altered residualization, all this can reduce the fertility. The junctional zone activity is very important because in normal ovulatory cycle, during or prior to ovulation, you see the peristatic activity from cervix to fundus and from fimbria to uterine cavity, thus favoring the transport of gametes, the ova and the sperms, thus favoring fertilization and implantation. But after ovulation, you see that the peristatic activity is not promoting this, preventing further fertilization and implantation. But because of adenomyosis, this type of activity can be altered, bringing down the chances of fertilization and implantation. Pivos et al. Observed that in patients with junctional zone more than, if the junctional zone is less than 10 millimeter, the pregnancy rates are around 45% per transfer. The rates can drop down to as low as 16% and 5% when the junctional zone thickness goes above 12 millimeter. So MRI evaluation of junctional zone thickness is the best negative predictor for implantation. So whenever you see an ultrasound, learn to measure the junctional zone also. There's also alteration of the myometrium from slight localized expansion of the junctional zone to massive myometrial hyperplasia and fibrosis. And this can change the plasticity and tonus of the uterus, as well as contour of endometrial cavity. And this could be the main reason for causing dysmenorrhea, menorrhagia, preterm labor, abortions, etc. This is a paper by Hashimoto et al. Where they have depicted beautifully the effects of adenomyosis on fertility. That is, chronic inflammation can cause impaired uteroplacental perfusion, leading to miscarriage, preterm delivery, placental malposition, preeclampsia, small for gestational age infant, etc. And there are very many papers which have shown that the chance of miscarriage are 32% in women with adenomyosis and 14% in women without adenomyosis. And there are any number of papers from 2006 to 2022 today. Zhuang et al., Machimoto, Hashimoto, Shin et al., who have shown that there can be preterm labor, PROM, small for date infants. All this has been studied beautifully over the last 16 to 18 years. So when these women come to you seeking fertility, she has dysmenorrhea, she has menorrhagia, but she wants fertility. Unlike the olden days, where you used to suggest surgery or hysterectomy, today you cannot do it. You have to be conservative because they want a baby. So it depends on the age of the woman, desire for fertility, whether it is diffuse or focal, and other associated factors. Does she have a fibroid? Does she have endometriosis? So need to do an overall assessment of the woman and then decide how you want to treat her. So you can treat them by medication, conservative surgery, and ART. As early as 1952, the surgical treatment has been described. It has given some results, but it's not ideal because there can be occasional chance of rupture uterus. So today, more and more, medical management is becoming popular, and peri passo, you can also use ART to help them to get pregnant because you cannot waste their precious years. The medication being NSAID, OCP are helpful for the pain relief, but danazol was a wonder drug in the yesteryears. Today, what is useful to us is GnRH analog. Danazol lost popularity because of the androgenic side effects. Today, what is popular is GnRH analog, Dynogest, aromatase inhibitor, intrauterine system with progestogens, and ART side by side. Uterine artery embolization and HIFU is being tried in infertile women, but it is more useful in women who have completed their parity. So how does GnRH work? GnRH reduces the expression of aromatase cytochrome P450 in the utopic endometrium of women with adenomyosis and endometriosis, reduces the expression of nitric oxide synthetase. But always remember that it causes profound hypoestrogenism. So it's very important to give progesterone add-back therapy whenever you use GnRH analog, because you need to use them for 3 to 6 cycles, because you need to achieve reduction in the size of adenomyoma as well as size of the uterus. when you use it for 2 to 6 months, GnRH can give a good uterine volume reduction. And the paper by Zhu et al., they've achieved a volume reduction from 180 ml to almost 86 ml, which is a very impressive uterine volume reduction by almost 60%. New et al. Found that a long course of downregulation significantly improved the clinical pregnancy rate, ongoing pregnancy rate, and implantation rate in patients with adenomyosis. And this has been also supported by Tulandi et al. In the recent papers in fertility sterility. If you do a surgery for adenomyoma, you have to wait for at least 4 to 6 months for a good uterine integrity. And you spend a lot of money and with the fear of occasional rupture uterus. But if you use GnRH analog, you can achieve the same. So I call it a medical adenomyomectomy, and there is no fear of rupture uterus. So we would say that this is very good method of treating instead of surgery. This is a paper by Holmes et al. From Netherlands. They concluded that when you use pre-ART, pre-embryo transfer GnRH suppression, there is no significant difference in any of the IVF ICSI outcomes in women with or without adenomyosis. The pregnancy rates and live birth rates were similar. Once again, New et al. In 2013 and Park et al. In 2016 concluded that there is a very good improvement in pregnancy rate without suppression of adenomyosis with GnRH. The pregnancy rates were 24%, and with GnRH suppression, the pregnancy rate jumped to 51%. Implantation rate went up from 16 to 32%, and ongoing pregnancy rate improved from 21 to 48% whenever you use pre-IVF GnRH suppression. Those days they did suppression prior to ovarian stimulation. But with this, the problem was that sometimes you require a longer duration of stimulation and higher dosage of ovarian stimulation. So today the trend is you decide depending on the patient's AMH and ovarian capacity. You can give an antagonist, collect the eggs, and then give a suppression for 3 to 6 months, depending on the size of the adenomyoma and other structures. And this is a beautiful paper by Tamerlan et al. They studied that the rate of euploid miscarriage, they transferred euploid embryos in these women, and they concluded that the miscarriage rate is increased in the setting of adenomyosis, though the embryos were euploid. But when they gave a GnRH suppression, there was a very good improvement in implantation rate, and it also reduced the number of miscarriages. It may also improve post-implantation pregnancy health. So this is a very important finding that by pre-ART suppression, you can get good pregnancy rates and reduce the number of miscarriages. This is one of our own patients who had a prior recurrent implantation failure. She had a subtle adenomyosis. We gave her a GnRH analog depot. At the end of 6 weeks, you hardly see any change. But at the end of 12 weeks, we could see that the adenomyoma regressed beautifully. The endometrium has expanded, except for a couple of small cystic areas. At the end of 16 weeks after GnRH depot, she underwent embryo transfer. She conceived twins, and she had a very good outcome. This is another lady with posterior adenomyosis, 4.7 centimeter adenomyosis, bilateral small cyst, posterior adhesions. She had already undergone laparoscopy elsewhere, and she also had a IVF failure. You can see this. It's causing a small indentation of the endometrial cavity. Whenever I present this in panel discussion, they always say, no, I won't do an adenomyomectomy because this is impinging on the endometrial cavity. But this lady, we suppressed for 16 weeks, and then we did an embryo transfer. She conceived a singleton pregnancy and went to 37 weeks beautifully without any problem. So there is no need for surgical adenomyomectomy. You do a medical adenomyomectomy. What about Dynogest? People ask me in every meeting, why can't we use Dynogest? Dynogest is very good for the suppression of dysmenorrhea, dyspareunia, chronic pelvic pain associated with adenomyosis. But the triptorelin acetate or leuprolide acetate seem to be superior to Dynogest in controlling menorrhagia and also for the reduction of uterine volume. The uterine volume reduction with Dynogest is not so impressive, takes a long time. The Dynogest gives you a good protection from loss of bone mineral density, but for volume reduction, nothing like GnRH analogs. This is a paper by Matsushima et al. They made a 16 weeks study with GnRH analog, low-dose estrogen progesterone, and Dynogest. Before treatment, the volume of uterus was 307 in the GnRH group. It came down to 177 cc. There is more than 50% volume reduction. Whereas in low-dose estrogen progesterone and Dynogest, there was no change at all. So GnRH analog is superior to low-dose estrogen progesterone or Dynogest. Aromatics are also found to be very good in reducing the uterine volume. When you use letrozole 2.5 milligram per day for 8 to 16 weeks, a very good volume reduction has been achieved. And at our center also, we have tried this. The paper by Kimura et al., the reduction in uterine volume was almost 60%. So there is a reduction in the uterine volume as well as the volume of uterus. Improving the fertility and chance of miscarriage also are much reduced. And this is a trial of comparing aromatase inhibitor plus GnRH analog versus Dynogest in women undergoing IVF in 2018. The pregnancy rate after a combination treatment was 48% compared to Dynogest group, which is only 20%. So the combination of letrozole with GnRH seem to be superior to Dynogest group. But whenever you give this suppression, you have to give norethistone acetate 5 milligram to reduce the loss of bone mineral density, which is very important. Mirena can be used in these women along with GnRH analog. It seems to be very good for causing decidualization of the endometrium and adenomyotic deposits. It can be used along with GnRH analog, gives a good volume reduction. And this is another paper which has shown that in the implantation rate in the LNG IUS group were 32% compared to control group, which is 22%. The clinical pregnancy rate was 44% in the LNG IUS group compared to 33% in the control. And the ongoing pregnancy rate was 41% in the LNG IUS group compared to 29%. We also have used this because many times a combination of GnRH with LNG IUS seems to be pretty good. And some ladies also have uterine polyps and thick endometrium that also can be counteracted with the help of GnRH analog plus intrauterine device. In the Europe, there is an ongoing trial of intrauterine device containing danazol. This can be used for about 6 months, reduces dysmenorrhea, dyspareunia, chronic pelvic pain with no androgenic side effects. You can use the same oral danazol by vaginal method, and there seems to be good reduction of uterine volume and adenomyosis also. But oral danazol is not used because the androgenic effects are high. This is a paper from China which has shown that if you can reach a uterine volume of less than 98 cc, the chances of miscarriage are much less. So who will benefit from uterus sparing surgery in adenomyosis? If somebody has abnormal uterine bleeding and severe dysmenorrhea, not responding to medication, recurrent abortion and recurrent implantation failure, where you did not get results with medical management, that's the only time that you have to go in for surgery and not otherwise. So you can, if there's a recurrent implantation failure or no response to medication, then you can go for surgery. Otherwise, try medical management as the first choice. A clinical pregnancy rate of 30 to 40% was obtained in women after adenomyomectomy. But the only problem of adenomyomectomy that it is not a simple surgery. Many of these patients can have grade 3 to grade 4 endometriosis. You can see here the posterior bulge of adenomyosis and lots of adhesions. You can sometimes also have a bowel adhesion. It is not like a simple cakewalk. One has to be very good in doing laparoscopic surgery for adenomyosis. Release all the adhesions, locate the ureter, do not get into problem. And when you start doing surgery, you do not know how to stop and where to stop because you do not have the touch sensation that you can get by open surgery. So it's only by a guesswork that you decide where to stop. When you start seeing a supple muscle, you think that you have reached the end of surgery, and then you stop doing surgery, and then you do a good approximation. Sometimes we'll have to do 2-layer approximation so that this uterus can withstand a good pregnancy, good apposition, and then wait for 4 to 6 months for a good healing. Do not allow her to get pregnant within 8 to 10 weeks. Myoma scar heals much better than adenomyosis scars. And according to Osada, there is another method by Sun et al., where instead of unipolar, they are using bipolar for the surface, and then go into the depth, remove the tumor, and then approximate in 2 layers. The first layer to approximate the tumor cavity, and the second layer to approximate the superficial muscle layer to achieve a better uterine integrity. And according to Osada, the master of the adenomyomectomy, he prefers open method. This is his video where he shows that you open the uterus completely into 2 halves, and then with the finger into the uterine cavity, you remove all the adenomyotic tissue and then do 3-flap technique of closure. And he prefers open method compared to laparoscopic method. According to him, you do a open method for diffuse adenomyosis, and for a focal adenomyosis, you can try the laparoscopic technique. And in Japan, in the biggest series of 2,100 procedures of adenomyomectomy, they had 6% chance of uterine rupture. When you do a cesarean, the chance of rupture are only about 1 in 1,000. And after a myomectomy, it is around 1%. But after adenomyomectomy, the chances are as high as 6 to 8%. That's why one has to be very careful in doing an adenomyomectomy and do it less often. And if necessary, do it by open method rather than laparoscopy. There was a report of ruptured uterus in a 33-year-old lady with twins in Japan. She had conceived 1 year after laparoscopic adenomyomectomy by IVF-ET. And at the stage of 32 weeks, she had sudden onset of severe abdominal pain, and she was receiving Ritordin drip. In spite of that, there was a ruptured uterus. They suspected the rupture and took her up for surgery, and they could save the babies. But this kind of catastrophe can be avoided if you avoid doing adenomyomectomy for diffuse cases. So according to Osada, for diffuse lesion, do open method, and for focal, you do laparoscopic method of adenomyomectomy. And hysteroscopic resection and endometrial ablation is more often done for women with who have completed their parity. One has to be careful in doing that type of surgery, hysteroscopic surgery, in young women who want fertility. This is a series of Rao Hospital. This was produced, present in ASCOG in 2016. In fact, Dr. Pai was one of the judges, and we got a prize for this presentation, poster presentation in Chennai. We had 56 patients with adenomyosis, focal 29, diffuse 27. 33 patients were managed by medical method, and we had a 44% pregnancy rate. Miscarriage rate was 32%, and live birth rate was 68%, which is very good. 66% pregnancy rate, live birth rate was very good. And we realized that many of these patients had with ovum donation, the success rate of pregnancy was more. It was 63% with ovum donation. With ONX, the pregnancy rates were something like 27%, because many of them come to you when the ovaries are already damaged, and they come when they are married for 15 years, 39 to 40-year age group. That's how many patients those days went in for ovum donation. Today, with early diagnosis, I'm sure you can avoid ovum donation and you can go in for their own eggs, because ovum donation is out of context now. So this is our chart where we had obtained 63% live birth rate. This is one of the patients with a large 6 centimeter posterior wall adenomyosis. She did very well with 6 months of suppression with 2 doses of GnRH analog, along with nor it is stone. She conceived twins and she had a 30 weeks delivery, but she did well. We could save the twins. Another patient who had 5 to 6 pregnancy losses. She was married to her own uncle. She came to us at 41 years. Again, she insisted that no surgery, but she failed in spite of three times embryo transfer, and she had missed abortion. And later she agreed for laparotomy and debulking, which were done in 2008. She conceived in 2008. She delivered twins after adenomyomectomy. This is one of the few cases that we had taken up for adenomyomectomy. This was her uterus post-delivery, post-LSCS. You can hardly see any indentation or adhesion or scarring in spite of open adenomyomectomy. This is one of our patients who had a cystic myometrial lesion. She already had one baby, a case of previous cesarean. She came with menorrhagia, enlarged uterus with 7 centimeter cystic lesion. This lady did very well with laparoscopic drainage of cyst, fulguration, followed by GnRH agonist 3.75 milligram, 2 doses, that is 6 months suppression. And we stopped the suppression. She naturally conceived and she came back to us for delivery, and she had a LSCS and a healthy child. And this child is today 15 years old. This is another patient who has undergone adenomyomectomy earlier elsewhere. She was 39-year-old with infertility of 15 years. She had recurrence within 1 year, one failed IVF elsewhere. You can see this was an old picture. Actually, you can see this was 6 centimeter posterior wall adenomyosis. She was suppressed with 2 doses of long GnRH agonist. We had a good reduction in the size of the adenomyosis. Then she had ICSI and embryo transfer at our hospital. 2 embryos became 3, but one of the twins vanished. One of the triplets vanished. You can see 3 sacs initially, later became twins. She had a little bleeding at 24 weeks due to low-lying placenta. In spite of that, she had a good outcome, 36 weeks LSCS, and she had twins, each weighing 2.7 and 2.2 kg in March 2007. This was one of her early pregnancies, early experience in 2007. And later, this is another case, 39 years. She has had laparotomy twice, laparoscopy thrice elsewhere, severe dysmenorrhea, thick endometrium, diffuse adenomyosis with endometriosis, previous 5 IVF failures. So the doubt here is, should you offer a surrogacy or should you do her transfer again? The husband was very reluctant to do any more embryo transfer. So this lady, we had to offer her egg donation. This was 3 years back. She initially had Dinoges, Mirena for 13 weeks. Then we did embryo transfer, no pregnancy. Later again, we suppressed her with 11.2 milligram leuprolide depot. And then we did embryo transfer and she conceived. So this lady, in spite of 5 IVF failures, she conceived with leuprolide suppression and she had a term birth. This baby is growing. Now she is 4 years in Tanjavur. So when you see women with adenomyosis, in young women, you treat them like anybody else. You do a routine infertility workup, including measurement of ovarian function and semen analysis. If it's a mild adenomyosis, you give her a chance to get pregnant, and many of them can even have a spontaneous conception, or you can do IUI. But if they do not conceive, do not go for surgery. You give a long GnRH suppression, do embryo transfer, and they may conceive. You at least try 1 or 2 trials of embryo transfer. Do not go for surgery. So if there is a repeated failure, then you go for surgery. So surgery will be the last resort. And if you give a GnRH suppression before embryo transfer, you will have a good success rate. Uterine artery embolization, you can try in Paris women, because sometimes you can have chances of ovarian failure. You can have chance of high rate of miscarriage, IUGR, preterm delivery. So we reserve it more often for women who have had pregnancy already. HIFU also is under trial. Once again, it seems to be effective in women had prior pregnancy, but there are occasionally reported cases of usage in infertility, and pregnancy rate has been reported, but more often we try it in gynec patients who have completed the parity. So to conclude, adenomyosis is a challenging condition to treat in the setting of subfertility. It is interesting to note that with ART, there was good pregnancy rate and good reproductive outcome in adenomyosis. Well-designed adequately powered studies are required to study the impact of adenomyosis in the treatment of subfertility. So thank you all for a patient listening. If you have any questions, you are welcome.
Thank you, Dr. Asha. I always appreciate because you have the vast experience and you are so dedicated to not only infertility in that. I always have seen you talk very confidently and with experience as far as adenomyosis is concerned. And I remember that paper where your son presented, and it was so wonderful. All the audience appreciated that. Obviously, he got the prize. It's
Thank
not
you.
me
Thank you
who
so
gave
much.
him the prize. And also, I have seen your setup where there is so much of dedication in the work, and whatever you have spoken today, it's out of your own personal experience and also, of course, review of literature. So congratulations and thank you very much. You have talked about the danazol IUCDs. Are they available now?
It is under trial in Europe, but we recently tried vaginal danazol, the same tablet we use vaginally for 3 months. And the suppression of the adenomyosis volume seemed to be good.
Okay. Now, but what actually this afternoon I gave a talk on same adenomyosis in Manipal. That time in one of my slides, I was telling that even though in adenomyosis the size comes down, that may not convert itself into improved fertility, because the main problem with adenomyosis is not just the size of it, which is coming in the way of implantation, but the other process that is there, the aseptic inflammatory reaction that happens, hostile endometrium, and even the release of nitric oxide, which is detrimental to the sperms, to the embryos and everything. So those things may not have changed.
So that's how the papers say that GnRH analogs reduce the nitric oxide synthetase,
Yeah,
and they reduce the
that's correct.
expression of aromatase. So there
That's
is
right.
suppression of adenomyotic deposits as well as the adverse effects in the utopic endometrium.
Correct.
And that's how it favors implantation.
Yes.
And promotes
That's
live birth
correct.
rates.
Yeah, that's correct with the respect
So even
to
when you do a
GnRH.
surgery, you have to go and give post-operative GnRH analog. So
Absolutely.
you may as well give it without surgery.
Yeah. Okay. That that is understandable. Any other questions?
And we also tried a combination of GnRH analog with aromatase.
Yeah.
In fact, that case I had not added in this series. The lady's uterine volume was around 340 cc, which is something like a 12-week size uterus.
Yeah, it's quite.
And this lady was already about 32 years and AMH was 1.3, 1.4. So we went ahead and did the egg collection, embryo vitrification, and she came during the COVID year. And from February 2020 to September 2020, we suppressed her with GnRH analog, aromatase plus norethistone acetate. The uterine volume came down to 200 cc. We could not really wait for 100 cc. At 200 cc, we transferred the embryos. She conceived singleton and she had a term birth, 37 weeks LSCS. We had tried it for about 10 patients, and I think about 4 of them did very well, a combination of GnRH plus aromatase.
Yes, good. So I would read some of the compliments first. Dr. Manjula Patil has written very interesting and elaborative and informative talk, ma'am. Dr. Bharti Rajshekhar, who is our secretary, she has written very crisp and clear.
Sorry, I was
Dr.
late.
Asha. And there's one question. What is your comment on cabergoline?
Cabergoline you can use for pain relief because there is always associated endometriosis, but I have no experience of using it for fertility.
Yeah. No,
because whenever we give GnRH, they go into amenorrhea and there is no more pain.
True.
And
true.
when you stop GnRH, you do the embryo transfer.
Yeah, maybe it has got an anti-angiogenic property. That's why, generally, as you said, both endometriosis and adenomyosis, it may help that way indirectly.
I found only one paper where they have studied cabergoline. There were not too many papers.
What about Marina? That is Manjula Patil's question.
Yes, in intrauterine device, we have used in quite a few patients. Wherever we see associated endometrial hyperplasia. Many patients have thick endometrium along with adenomyosis. And those patients do very well if you give a combination of GnRH analog suppression along with intrauterine device. And there is a good suppression of endometrium. And when you stop the suppression and try embryo transfer, the endometrium regenerates and they do very well. Just giving Mirena for about 6 to 8 weeks is not enough. You should use it for minimum 12 to 16 weeks if the endometrium is thick.
Okay.
And no point in using it in women who already have thin endometrium. Do not use in such patients. Use it for patients with thick endometrium.
Okay. So can you map adenomyosis is another question by Manjula Patil.
Mapping the adenomyosis is possible with the good 3D ultrasound. Today we have been working from last 2013 with the E8. But today we are ruling for E10, because with that, the better machine you have, better is the mapping of adenomyosis. You do not need to necessarily go in for MRI.
Okay.
But these machines will cost again about 80 lakhs or so.
Okay. Dr. Anita Rajoria from Delhi, she is asking how fast adenomyosis comes back post-delivery or LSCS?
Post-delivery or LSCS, they are breastfeeding, promote breastfeeding. And I tell my patients always at the end of 8 to 9 months, you go in for an intrauterine device. Do not wait for the symptoms to recur.
Yes.
But quite a few patients, they do not come back until they start suffering with pain. So these women typically came back at around 15 to 16 months after delivery or LSCS because the pain started, because they're feeding the baby for 9 to 12 months. When they stop breastfeeding, another 4 to 5 months, the pain has recurred. So typically they come around 1.5 years after childbirth, rolling in pain. And then again, you have to give them GnRH suppression, followed by Mirena, because if you do that, your chance of expulsion are much less.
Okay. For Manjula Patil is asking too many questions today. Maybe she could directly ask. Anyway, her question is how long to use medical management for infertility patients?
Yeah, this is a good question because there are no yardsticks so far. How long you have to use, how much volume reduction you have to achieve. There are papers from China which said you wait for 98 cc, but it's not possible to reach 98 cc because our patient who had 340 cc, if you want 98 cc, then you have to suppress it for 2 years. In 2 years, what is the amount of bone loss she will have? So our patient with 340 cc, we waited up to 200 cc. 200 cc is still a little big uterus, like 8 to 10 weeks.
Yes.
But the lady conceived and she did very well.
Good.
So there are no yardsticks so far.
Bharti Rajshekar's hand is up. Bharti, you may yourself talk.
Yes, Dr. Asha, thank you for coming to KCOG Kasoga. I'm sorry for being late. Well, my question is, if somebody has like a postnatal, she's had a family, she's not worried about fertility issues, but she has an adenomyoma and it is giving her irregular bleeding and pain. So is Mirena the first choice or would you go for anything else? Or go for GnRH only?
If it's a small uterus, not too many problems, I'll go in for Mirena straight. Otherwise, I prefer to use GnRH suppression, which is my first priority. And at the end of 8 weeks or 10 weeks, we would put a intrauterine device. And a lady who was 30 years, she was pretty fat, she was about 95 kg with one baby of 5 years. She says, I may want fertility again. So do not do anything for me because she also had chocolate cysts and hydrosalpinx. Once you put in a telescope, we'll have to go for the complete works. That means she may land up even with the oophorectomy if she really wants a relief. No point in just removing the cyst in these ladies. So we gave her a GnRH suppression for 12 weeks. And we gave her another depot because even at the end of 10 weeks, she was having pain. So to reach complete amenorrhea, it was 12 weeks. And at the end of 12 weeks, we gave her another 3.7 and we gave her a Mirena. And she has done very well. It's about 6 years now. And now she's coming back and saying, remove this Mirena and give me a new Mirena because now she started having symptoms at the end of 6 years.
So how long do you continue GnRH? Like you said, about 1 to 2 years is okay? Or only for about 10 weeks?
GnRH for about 16 weeks.
Yeah, that is 2 to 3 doses.
Yeah. And in between, after 1 year, she had come to us with a little recurrence of pain. We gave her a Dynogest for about 8 weeks.
Okay.
And now it is 6 years.
Yeah, and
She
you
came during
mentioned
the
that.
COVID year and she said, no, do not remove ma'am now. Let me wait for the
Yeah.
COVID to be over. And she came last month and she said she wants to remove it and insert a new one.
And what if, like you spoke about GnRH with the aromatase inhibitors and norethistérone. So what is the dosage of aromatase inhibitor and norethistérone that you prescribe for them?
I have always given 2.5 milligram twice daily.
Okay.
Along with GnRH, which you can give for 12 to 16 weeks. Our patient who are at 330 uterine volume, we suppress for 6 months.
Okay.
So 11.252 doses.
And
Along
what
with
about the norethistérone? You said along with that.
5 milligram. 5 milligram.
5 milligram north. Thank you. Thank you, Asha.
Yeah.
Very practical and very informative. And this interesting point that you stressed that the open method of adenomyoma in case of diffuse adenomyosis, is it still being followed in many centers here? Because most of us are doing
Most
the
of the
laparoscopy.
doctors are very enthusiastic to go and
Laparoscopic.
do adenomyomectomy.
Yeah.
Whenever I show my patient with 4.7 centimeter adenomyoma, they're all very enthusiastic. Recently, we had a panel in Bangalore, and I was quite surprised when all the panelists said adenomyomectomy, and they're not actually doing an adenomyomectomy. If you do one adenomyomectomy per year, what is your experience? You're not going to get any experience. So, a surgeon like me, we did an open adenomyomectomy. Today, Damodar is quite enthusiastic for for a laparoscopic. But most of the patients we are able to suppress with GnRH and give them a baby. So,
Okay.
what is the need for adenomyomectomy? So, I always say that do a medical adenomyomectomy rather than surgical adenomyomectomy.
I think that's a good suggestion and a point to be taken home.
Unless there is no response, or if there's a miscarriage in spite of good suppression, maybe that's the only time that you have to go in for surgical adenomyomectomy.
Yeah. Thank you, Asha.
Tell the patient always about rapid chance of recurrence.
Yeah, once he stops the therapy.
Yeah, there is another compliment from Dean MC. Good evening to all. Nice presentation, Asha madam. And from Arti's iPad, there's a question. What is the cutoff size for use of Dynogest in chocolate cyst?
Cutoff size for use of Dynogest in chocolate cyst. If somebody who wants fertility will never use Dynogest, because today's topic is fertility. And if fertility is not a problem, if she is symptomatic, even if the chocolate cyst is 1 centimeter, you can use Dynogest because it's basically used for pain relief.
Okay.
So it's very good for pain relief. So you can use Dynogest even up to 5 years.
Yeah. There's one more question. Very nice presentation, ma'am. Choice of medication in premenopausal lady with symptomatic adenomyosis.
My choice is intrauterine device. With intrauterine device, if she still has pain, you can use temporarily Dynogest. And they settle down and they can continue the intrauterine device. One of my patients had the intrauterine device at the age of 49. She was a doctor's wife, asthmatic. She said, I do not want hysterectomy and chocolate cystectomy. She had tiny chocolate cyst, 3 centimeter, but she was getting a lot of pain. She did very well with the intrauterine device and she kept it for about 5 to 6 years. And she has escaped a hysterectomy.
Okay. Thank you very much for such a lovely talk which generated so much of discussion and you answered all the questions patiently and nicely. Thank you very much. So I would request Dr. Manjula Patil to deliver the...
Dr. Murli, Dr. Kasturi Donimata, President Kasoga is there. If she wants to say something.
She welcomed already.
Okay.
She welcomed. So Manjula's privilege.
I was very happy to have gone to Hubli and met Dr. Kasturi. Such a warm person.
Dr. Kasturi, would you like to wind up the session with your remarks?
Excellent talk, Dr. Asha madam. It was really, with your vast experience, lots of take-home messages. Day to day, seeing so many adenomyosis cases. In the past, it was only in the older people. Now, though, all young people are having adenomyosis, many infertility cases. Your talk was really good. So many take-home messages, which we can really implement in your day-to-day practice. From your vast experience, it really makes a difference for people who have attended, and they can make a difference in the patients' lives and fertility in future in many patients. Thank you so much for making so much difference in our practices. One thing I just had, in literature it is shown that endometrial ablation can also be a treatment for
Yes, in
adenomyosis.
Paris women, you can definitely try. I said hysteroscopic ablation can be tried, but a word of caution in Paris women. Because if you burn their endometrium, then there is no further fertility.
Okay.
Whereas a person who has had one child or two children, not interested in fertility, okay, we have done endometrial ablation. It can work well. So thank you so much, Dr. Kasturi, Dr. Pai, Dr. Bharti, for giving me the opportunity and also for your appreciation.
Yeah.
You may
Dr.
begin.
Manjula, can you unmute yourself and deliver the vote of thanks?
Okay, sir, it's my pleasure. Asha ma'am, it was really a wonderful talk, and it was really a very practical tips to manage adenomyosis, even for infertility as well as for other gynec problems. And I thank KCOG chairman, dean and director, Hema ma'am, and secretary with Dr. Vidya Bhatt and chairperson Muralidhar Paisa, and also our Kasoga patron MG sir, Nagraj sir, secretary Dr. Bharti ma'am, and president Kasturi ma'am, and all the delegates who have took their time to experience this beautiful and informative talk. And Asha ma'am, it was really a wonderful talk, and happy to be
Yeah, and just
over
one
this, ma'am.
suggestion before I wind up. March is the month for endometriosis.
Endometriosis.
And I'm requesting all of you to make small programs. You do not have to spend too much. Maybe